in technology.
Yeah, I know. You're in Australia, we are here. This meeting is being live streamed, okay?
Oh, fantastic. Well, it is my first to be live streamed. I've never been in a live streamed meeting. So I guess one thing that come out of that clearly comes out of that is the internet quality has improved all over the world, whether it is Australia or India, Telangana, the internet quality has improved.
Yeah,
so we're able to live stream it. While we're waiting for other people, I would encourage trainees, especially postgraduate students, to take a pen and paper and work out as we go through. I'll give you a bit of time when we come to the examples. If you can go through the steps that are taught in this lecture and use them to work out those examples. I might give you about 10-15 seconds before I move on to the next slide.
Dr. Veeru, I'm just waiting for Dr. Deepa, sir. Once he joins, we'll start, okay?
Sure, sure.
Good evening, everybody. I am Dr. Veer.
Video, audio,
Good evening, Dr. Veeresham. Dr. Veeru,
Yeah,
he
good
is
evening.
Veeresham is the state ISA president. So the other members are not able to join due to various reasons. So shall we start, Dr. I'll just give you a brief introduction. So good evening, everyone. I'm glad to introduce Dr. Veerendra Jagar Lamodi, who is here with us, though it is late night for him. He is of ABG Analysis. And he has an intensivist who has been trained in with full anesthesiology qualifications from our India. He has done his MBBS from Medical College in 2000 and MD from Nizam's Institute of Medical Sciences in 2005. After working as a senior resident in NIMS and in Bangalore also, then he joined as a senior registrar of ICU and in general medicine in the Wollongong Hospital of Australia. And in 2012, he has done his FICCM. Now, at present, he is a full-time permanent staff specialist with clinical and non-clinical roles, and he is the supervisor of training for the College of Intensive Care Medicine Trainees. He is also a member of the District Infection Control Committee from 2019 till date. He is a member of the Microbial Stewardship Committee in Australia. Many awards to his credit as a resident in NIMS as well as in India, and he has got the Memorial Award and Australia Travel Agent. And I welcome Dr. Veerendra to speak about ABG.
Thank you very much, ma'am. Thank you very much for your kind introduction, and thank you for the invitation to speak. I find it as a great honor to speak wherever, especially India, especially the Hyderabad, the city that I've trained, I had my foundation training in. Thank you. So today's talk is about arterial blood gas analysis. So we will go through a few steps. It's very practical, simple steps to interpret how to interpret an arterial blood gas. The usual way I do this talk is take those examples and ask the audience face to face. Because this is a Zoom talk and a live stream talk, what I request people to do is take a pen and paper, and as I go through the examples, can you try and solve those examples with the principles being taught in this lecture? And that's the way to get most benefit out of this talk. So without much more ado, we'll go into the talk. So the discussion of acid-base analysis in this talk is from the traditional or the empiric Boston school of acid-base analysis. And this is the most common way acid bases are taught to be interpreted. So the other approach that has gotten some weight is the Stewart approach. Although Stewart was one of the pioneers in his own approach, that was difficult to explain, and it didn't get much traction until recently. But recent research has largely confirmed that whatever approach you use, the results are similar. But most teaching and most institutes still follow the Boston school, which is being taught in today's lecture. So the Boston approach, it was first described in 1963. It's based on work in humans, simple and easy to teach. It emphasizes clinical assessment and interpretation, and there are 6 rules. You just need to remember the 6 rules, and you should be able to interpret any gas. And if you look at the end of this presentation, you'll be able to see how you can even identify triple disorders. So when we talk about arterial blood gases, many people worry about, oh, how am I going to identify a metabolic alkalosis, a metabolic acidosis, and a respiratory disorder? How am I going to identify all 3? How is this person able to identify all 3? Well, if you follow the rules described in this lecture, you will be able to identify double disorders and triple disorders. Can anyone think of what 2 disorders cannot coexist in terms of acid bases? And if you think of the 2 disorders that cannot coexist, can you just type it in the chat, please? So the 7 rules, the first, when you look at a gas, you look at what is the pH. So when you look at what is the pH, for example, if I say pH is 7.25, what does come to your mind? You should think, okay, pH is acidemic. When you describe any change in pH, you should use the word emic because it's in blood. So that's why acidemia, acidosis. Acidosis is, if you're describing a respiratory acidosis or a metabolic acidosis, you call it acidosis. When you call the change which is in blood, you call it acidemic. So if you look at the pH, you can look at the pH and say, okay, is this pH acidemia or alkalemia or normal? So once you identify what the pH change is, then the next step is to look at whether that primary change is respiratory or metabolic. Now, I will just pause. This is the point I usually ask a member of the audience to say, how do you identify whether the primary change is respiratory or metabolic? Now, because this is a Zoom lecture, I would like you to think. Let's say the pH is 7.25. The next step should be you look at the CO2. If the CO2 is high, then you can say the primary change, which is acidemia, is coming from the high CO2, which means we are dealing with the respiratory acidosis as a primary change. I hope that makes sense. If the CO2, alternatively, the CO2 is low while the pH is low, which is primary change is acidemic, but the CO2 has gone lower, which is CO2 showing respiratory alkalosis, which means the primary change in the pH is not respiratory. So if it is not respiratory, it has to be metabolic. So that's how the first step, you look at the CO2 and determine whether the primary change in the pH is in line with the movement in the CO2 or against the movement in the CO2, thereby determining whether it is respiratory or metabolic. The next step would be, if the primary change is respiratory, what is the expected bicarb? Then I'll tell you in the subsequent slides what rules apply. When I talked about 6 rules of acid base in the Boston approach, some of the rules apply to the respiratory changes. When there is respiratory cause of the problem, what happens to the bicarb? So I would like you guys to think about now, when pH is acidemic, when CO2 is high, that means there is a respiratory acidosis. Which direction do you expect the bicarb to move as a compensatory mechanism? Think about it. If there is high CO2, bicarb as a compensatory mechanism goes higher. There is low CO2, bicarb drops as a compensatory mechanism. Now, if the primary change is not metabolic, you need to think about what is the expected carbon dioxide. Again, there are rules in the Boston approach that we are going to discuss and teach what would be the expected carbon dioxide. And then after these 4 steps, never forget to do the anion gap. What is the anion gap? And if there is increased anion gap, what is the corrected bicarb? And this is the point in the lecture. By this time, everybody should think, oh my God, this is going to be a boring lecture. This guy is going to bore us to death for the next hour. But I will try and prove you wrong with the subsequent slides, because it's going to be, we are going to describe each of those points that we just mentioned. Now, the respiratory rules. Think about respiratory acidosis causing primary pH change, which means the pH will be lower, carbon dioxide will be higher. Now, for the purposes of interpretation in this lecture, or anytime you interpret blood gases, I request you and I recommend using set values. You know how when we ask normal values in an examination, you're supposed to answer in a range. I ask you what the normal CO2 is. You guys might say 35 to 44. But for the purposes of ABG interpretation, you need to identify a set number and use that instead of a range. So I'm going to say 7.4 is normal pH. 40 millimeters of mercury is normal CO2. 24 millimoles per liter is normal bicarb. 12, if we don't use potassium in the calculation, 12 is normal anion gap. Okay, hope it all makes sense. Now, respiratory acidosis. In an acute respiratory acidosis, which is a respiratory acidosis lasting less than 12 to 24 hours, because I'm speaking to a group of anesthetists, they should know what an acute respiratory acidosis is, because some of the medication we administer, would cause acute respiratory acidosis. Now, for each 10 millimeter mercury rise in CO2, your bicarb should go up by 1. in an acute respiratory acidosis. In a chronic respiratory acidosis, now this is a beautiful thing that we use in intensive care. We use it a lot. A patient comes in, an emergency department calls and says, oh, this patient's CO2 is 70. Okay. But they're not distressed. Do you want to take them? Sure. What is their bicarb? Now, if they're used to that CO2, when I say 70, it has gone up by how many lots of 10? Considering normal is 40, it has gone up by 3 lots of 10. So for each lot of 10, in a chronic respiratory acidosis, your bicarb should go up by 4. So for 70, if assuming normal bicarb is 24, the bicarb should have gone up by 3 lots of 4, because it's 3 lots of 10 from 40 to 70. So that is 12. So 24 plus 12 is 32. So if this patient's bicarb is 32, we'll say, listen, this patient is used to a carbon dioxide 70. It is chronic. They don't need an urgent admission to intensive care. That bed can be saved for someone else. This patient is not distressed. They're used to that CO2. And that's how a chronic respiratory acidosis can be easily diagnosed. Sometimes their CO2 is 80 or 90 and their pH is lower, but their bicarb is 32, which means there is an acute and chronic component where you need admission to intensive care to treat that acute component. Respiratory alkalosis. In an acute respiratory alkalosis, like someone is having sepsis, a panic attack, pain, for each 10 millimeter mercury drop in CO2, your bicarb should go down by 2. Now, if this is too confusing and if you don't want to remember 1 and 4, 2 and 5, just remember 1 and 4. And if you use them for respiratory alkalosis as well, that will be fine. But for completion and technicality purposes, I'll say for each 10 millimeter mercury drop in CO2 in an acute respiratory alkalosis, your expected bicarb should go down by about 2 for each lot of 10. So if the CO2 goes down from 40 to 20, that's 2 lots of 10, your bicarb should go down by 2 lots of 2, which is 4, if it is a fully compensated acute respiratory alkalosis. And in a chronic respiratory alkalosis, which is probably the rarest acid-base disorder that you'll ever see, bicarb should go down by 5 for each lot of 10 millimeter mercury drop in CO2. Now, I hope the boring, informative bit of the lecture has finished. The thought-provoking part of the lecture has started. Let's see if you guys agree with me. So a 23-year-old man found to be apneic and unresponsive in the surgery ward following reconstructive knee surgery. But 30 minutes earlier, he received 25 milligrams, big dose, not unusual in the West, but received 25 milligrams of morphine for pain relief. While he's being assessed and resuscitated, a blood gas sample was taken. Now, don't stress about not having all the values. For the purposes of this example, only these values are given. So this is the time where I'll give you 10 to 15 second pause for you to go through the gas yourself. I have a stopwatch in front of me.
Answers can be put in the chat box.
Yeah, that'll be good too, if I can see it. Anyways, so the pH, so the pH is acidemic. So the next step is looking at the CO2 to see if the direction of the pH is in line with the direction of the CO2. Yes, it is, because the CO2 has gone up, pH has gone down. Carbon dioxide is an acid. When acid builds up, pH drops. considering pH drop means acidosis. I'm pretty sure you should all be aware of that because it's a negative logarithm of hydrogen ion concentration. So pH 7.08 acidemic, carbon dioxide in line with the pH change, which makes it respiratory acidosis. Most of you should be aware what caused the respiratory acidosis. Morphine, respiratory depression. So now the next step would be, it's an acute respiratory acidosis. How many lots of 10 the carbon dioxide has changed? Changed by 4 lots of 10, considering normal is 40. So if it's changed by 4 lots of 10, you expect the bicarb to go up as a compensation by about 4. So considering normal is 24, add 4, your expected bicarb should be 28. What is the expected bicarb? 23. So this is from the information given to us, this is an uncompensated respiratory acidosis. Simple. Next one. Okay. So 26-year-old lady is undergoing treatment for frequent panic attacks. I guess one of the ways to describe panic attacks is hysteria. The attacks are accompanied by hyperventilation, tachycardia, dizziness, feelings of unreality, and tingling in the hands. You all know why tingling happens with this respiratory alkalosis, I think. I've given it away. In one particularly severe attack, when taken to the ED, an arterial blood gas sample was taken. pH, give you the 10 seconds actually. Right, that's 10 to 15 seconds. So I hope most of you are able to interpret this. So pH is on the alkalemic side. Because the change is in blood, we are going to say emia, alkalemic side. Next step is to look at whether the carbon dioxide movement in the carbon dioxide does explain the change in the pH. I would say yes, because pH is alkalemic, carbon dioxide has gone down. So there is respiratory alkalosis. Blowing out of the respiratory acid has led to the pH change. So how many lots of, so this is probably an acute respiratory alkalosis. She's having an attack right now. So in an acute respiratory alkalosis, we said for each 10 millimeter mercury change in CO2, the bicarb should drop by 2. So this has gone down by 10 and a bit. So let's say, how many lots of 10? 1.5 lots of 10. So it has gone down from 40 to 30, from 30 to 26. So 1.5 lots of 10. So you expect the change in bicarb to be about, so for each lot of 10 it is 2, for another lot of half a lot of 10 it's 1, so it's about 3. So 1.5 times 2 is 3. So you expect the bicarb to be 24 minus 3, 21. Now, as you can see, the bicarb is about 22. So it's there and thereabouts. So you can say this is a partially compensated respiratory alkalosis. Does it make sense? I can't see the chat. So if anyone doesn't understand how, or has a burning doubt, or is disagreeing with me, I would love that, but I would like you to unmute and speak, please, because I can't access the chat for some reason. Right. Now coming to the metabolic rules, because we have talked about the respiratory rules, so the metabolic rules. Now, most people, when preparing for PG entrances or studying for their internal medicine final exams, would have seen this expected CO2 equal to 1.5 times bicarb plus 8 plus or minus 2. If you have seen it, I have presented this lecture about 20 times and I can't remember that equation, and I don't want to try and remember that equation. So I'll tell you an easy trick. I'll tell you a trick that you can practice, that is reproducible, that is easily teachable, which is, think about pH. When you think about pH, for example, if I say pH is 7.4526, just remember the number, 4526, 7.4526. When I ask you, can you tell me what the last two digits of the pH are? If you answer anything other than 45, you're wrong. So when I ask you, when I say 7.4526, I say last two digits of the pH, it is the two digits that are next to the decimal point. So it's 45. So ignore the rest of the numbers. They are a waste of time. Just the two numbers that are next to the decimal point are the numbers you're looking for. Once you catch those two numbers, then for a metabolic acidosis, your expected carbon dioxide, because that's the compensatory mechanism for a metabolic change, your expected carbon dioxide, once you identify the last two digits of the pH, in this case 4,5, your carbon dioxide should be plus or minus 4 within that number. So if I say 44.5, so take it as 45 plus 4, 45 minus 4. So your carbon dioxide should be between 41 and 49. So that's how either in a metabolic alkalosis or a metabolic acidosis, your expected CO2 should be last two digits of the pH, plus or minus 4. Very simple. So that makes, you don't need to remember the 0.7 times bicarb plus 20 or 1.5 times bicarb plus 8 plus or minus 2. It's just too much of a number to remember. Okay, that makes it very simple and works most of the time. All right. So let's come to, I've just talked about respiratory rules. We've had a couple of respiratory examples. So it's anybody's guess now to say that the next example would be metabolic changes. So a 4-week-old baby boy is admitted to hospital with a history of projectile vomiting of several days duration. The following blood gases are obtained. I'll give you 20 seconds here. Just go through which direction is the pH change. Then does the carbon dioxide explain the pH change? Right. So the pH change is alkalemic. So there is alkalemia. The next step is to look at the carbon dioxide. If you look at the carbon dioxide is high, which means there is buildup of respiratory acid. That can't explain the pH change, which means the primary change in pH is not respiratory, which means it's metabolic. The primary change in pH being alkalemic and it's not respiratory, it has to be metabolic alkalosis. And we all know why this baby boy admitted with projectile vomiting has metabolic alkalosis. I mean, it's something that you guys commonly see in terms of a procedure. Now, with regards to the next step would be, once we identified there is a metabolic problem, in this case alkalosis, you need to think about, okay, has the carbon dioxide compensated enough? From the last rule, we know that to identify how much is the compensation, we need to say 50 plus or minus 4. So 46 to 54 should be the carbon dioxide. Carbon dioxide is 49. So it's a compensated metabolic alkalosis. Right? Make sense? Next slide. Okay. Let's now come to the concept of anion gap. Now, anion gap, there actually is no anion gap in plasma. Anion gap is a number because we cannot directly measure the negative charge on albumin, which is one of the biggest in terms of amount proteins in the blood. And we can identify the measured cations and anions easily. There is an apparent gap that is filled up usually by unmeasured anions, which are the proteins, your lactate, your acetoacetate, if they build up, or some of those pathological foreign negatively charged anions, which I will discuss in the next slide. Now, for the purposes of this lecture, we are going to use, or any ABG interpretation, we are going to use sodium minus chloride plus bicarbonate as the anion gap. We are not using potassium. So if you are not using potassium, I would request and recommend you to take 12 as the normal anion gap, because we can't use reference ranges. We have to use a number if you are trying to identify whether there is an anion gap or not. That's 12 is the normal anion gap. So if you look at this, so normally there is your cations. It's in this picture, it's only represented by sodium, but there is also potassium, calcium, magnesium, but there is anions, which is your bicarbon chloride, and also what comprises of the normal anion gap is proteins, negative charge on the proteins mainly, and there's also phosphate, sulfate, and other anions. That's why when you take in the sodium minus bicarb plus chloride, there is an apparent gap of 12, because that is where the albumin, negative charge in the albumin comes. But if that gap is increased, then you would have to say there is another external anion which is added to the mix, whether it is ketoacetate, or in terms of ketoacidosis, or your lactate, something else has been added, or the sulfates and phosphates that build up in renal failure. Now, the limitations of anion gap are, when the anion gap is more than 30, there is 100% of the time there is acidosis. But when the anion gap is 20 to 30, acidosis existed only 67% of the time, or 2/3 of the time. So not necessary that if there is an anion gap, there has to be an acidosis. So that's what the data shows. Significant amount of lactic acidosis may be associated with the normal anion gap. That could be because of the drop in albumin in sick patients, apparently reducing the anion gap. If you look at this, if the normal anion gap is reduced because of a drop in albumin, then even though there is another anion, you might not see it in the anion gap. So now, so the causes of high anion gap metabolic acidemia are your ketoacidosis, whether it's from DKA, diabetic ketoacidosis, alcoholism, or starvation, renal failure, uremia, and accumulation of renal acids, ingestion of poisons, methanol. I don't know if methyl alcohol poisoning is still a thing in India, but it used to be a thing at some point of time. Ethylene glycol is much more common poison in the West because it's an antifreeze agent for colder climates. Salicylates should be a common poison there. Lactic acidosis for because of various causes. I hope at least some of you know what pyroglutamic acid acidosis is. It happens in chronic paracetamol overdosage. Now, I'm going to tell you a little esoteric concept, a concept of corrected bicarb, which is, this is what it is. I'll go back a few slides ahead. I'll go back a few slides and I'll tell you. Okay, if you look at this normal anion gap, if that is made up of the proteins, if you add an additional anion in the mix, because of electroneutrality, you need to have the same amount of reduction in the bicarb. For another anion to join this side of the equation, bicarb would go down to maintain electroneutrality. So just stay with that concept for a bit. When there is high anion gap metabolic acidosis, as much the anion gap increases, bicarb actually goes down by that much. So what we do is we assume the normal anion gap in that patient to be 12. You identify there is a gap, there is an extra anion gap. For example, anion gap comes out to be 25. You then measure something called as the delta anion gap, which is you take the patient's anion gap, subtract it by the normal anion gap. Whatever you get, you then add it to the bicarb. Why are you doing this? Because you expect the bicarb to have gone down by that much. And when you add that to the bicarb, you expect the bicarb to normalize once you add the delta anion gap. Now, if it doesn't normalize, that's when you're looking at an additional disorder. So your measured bicarb on the blood gas plus your measured anion gap minus 12, which is the normal anion gap, should get you back to normal bicarb of 24. That's called corrected bicarb, as opposed to expected bicarb in respiratory disorders. That's different to this. If that corrected bicarb is more than 30, which means when you normalize the bicarb to anion gap, whatever the change in anion gap is, if the bicarb is way more than 30, normal being 24, then that's when you would say there is an additional metabolic alkalosis present. Or if the bicarb is less than 12, despite you correcting for it, it's still less than 18, then you, sorry, I said less than 12, I apologize. If it is still less than 18 after correcting for the anion gap, then you would say there is an additional metabolic non-anion gap acidosis present, along with the high anion gap acidosis. So while I go through the example slowly, you might be able to better understand this concept. Right. So a 19-year-old diabetic girl presents with 4-day history of vomiting and increased lethargy. So these are the initial investigations. So slow down and go through the steps that we discussed. I'll give you about a half minute. Right. So pH is 7.27, which is acidemic. So the next step is to look at carbon dioxide. Is the carbon dioxide, has it changed? Yes, it has. What has it done? It has gone down, which means it has gone to the alkalemic side, but the pH is on the acidemic side. So the carbon dioxide change doesn't explain the pH change, which means this has to be a metabolic acidosis. Once we identify metabolic acidosis, the next step would be to look at whether the carbon dioxide, what is the expected CO2? So 27 plus or minus 4. 27 plus 4 is 31. 27 minus 4 is 23. So pH is right on the cusp of that. So that's good. So it's a compensated metabolic acidosis. The next step would be to check anion gap. So 132 plus minus 83 plus 10, which is 93. So there is about 39. So anion gap is 39. So this 19-year-old diabetic girl, most likely a type 1 diabetic, has a diabetic ketoacidosis. We can all go home now. No, we can't, because we've identified the anion gap of 39. Normal anion gap is 12. Subtract that from the 39. So you should get about 27. You add that 27 back to the bicarb, which is 10. That has gone up to 37. So instead of normalizing to 24, corrected bicarb is 37, very high, which means this 19-year-old girl, along with having diabetic ketoacidosis, also has a contraction alkalosis or also acid loss alkalosis from the vomiting. So that's what it is here. Look at her glucose, 34.5. I'm sorry, I'm using units in 34.5 millimoles. You just times, I think 18 will give you sugars in milligrams per deciliter. Okay, so normal anion gap metabolic acidosis, often referred to as hyperchloremic acidosis. So there are usually 3 causes. Usually the answer is clinically obvious. Renal bicarbonate loss, renal tubular acidosis. Bowel bicarbonate loss, diarrhea. or mineral acid gain. Saline infusion, which is normal saline infusion, causes, because it's a fluid with a higher chloride content equal to the sodium, you will cause a dilutional acidosis. In difficult cases, when the history is not very apparent, you can work out through what you call as urinary anion gap. Have a look at this. The main measured cations in urine are sodium and potassium, and main measured anion is chloride. Urinary anion gap is sodium plus potassium in urine minus chloride. Now, the main unmeasured variable that is creating an apparent anion gap is the ammonium. So if the person loses bicarbonate from the bowel, like a diarrhea, then the kidney excretes hydrogen ions in the form of ammonium, so which takes up the cation space in the urine. And so that's why your urinary anion gap, the apparent gap, because the sodium excretion, sodium or potassium excretion is replaced by ammonium, which you're not measuring, you will cause a decreasing urinary anion gap, right? So which means in a gut cause of normal anion gap metabolic acidosis, your urinary anion gap is negative. So it's a way to remember. So it's a twist on the spelling. Instead of negative, it's NGUT, negative. So if you lose bicarb from the kidney cannot compensate for its own cause. It can compensate in certain renal tubular disorders, but I'm making a generalization that it cannot compensate, and that's why urinary anion gap is positive in kidney disorders. Right. So a 49-year-old man with a history of kidney stones is being investigated for hypertension. His urine has a pH of 6. Urinary anion gap is 10, which is not negative, which is positive. An arterial blood gas sample provides the following. Give you a minute. .20. Okay. If you look at this, pH is acidemic. Does the respiratory carbon dioxide change explain the change in the pH? No, it's in the opposite direction. So which means this is a metabolic acidosis. In a metabolic acidosis, the next step would be to look at CO2. So last two digits of pH, which is 30, plus or minus 4, which is 34, or between 26 and 34. PCO2 is 28, compensated metabolic acidosis. Next step would be to look at anion gap. So the anion gap, sodium is 135, chloride plus bicarb is 125. So anion gap is 10. So anion gap is normal. So there is metabolic acidosis and there is no high anion gap. So it has to be normal anion gap metabolic acidosis. So this gentleman has renal tubular acidosis. So a 39-year-old woman with severe chronic back pain is treated aggressively with NSAIDs for a number of years. NSAIDs, non-steroidal anti-inflammatory agents, let's say in this case ibuprofen. At a routine clinical visit, her blood pressure is found to be elevated. Her urine dipstick is 2+ positive for protein with a specific gravity of 1. pH is 5, ABG sample. Now, because this is very similar example to the last one, we'll go a bit quickly. pH is 7.3, acidemia, PCO2 is low, respiratory alkalosis, which is not explaining the pH change, which means this is a metabolic acidosis. What is the expected CO2? 30 plus 4, 30 minus 4, 26 to 34, it's 32, compensated metabolic acidosis. The next step would be anion gap. Add the bicarb to the chloride, which makes it 126. 138 minus 126 is 6, which is normal. It's 12. It's normal anion gap metabolic acidosis, which means this lady has renal tubular acidosis from NSAID usage. All right. A 35-year-old man is admitted to high dependency unit with a pneumonia. after spending 24 hours in ED. He is in negative balance following a diuretic therapy. His initial bloods on arrival show this. Now this, we are coming to the last 3 or 4 examples. The examples get trickier as we come to this point. So I'll go through this example. So change in pH is alkalemic. But the next step would be to look at carbon dioxide. Does the carbon dioxide change explain the change in pH? Yes, it does. So there is a primary respiratory alkalosis present. Now, this is a point where people can make a mistake and say, okay, I've explained the change in pH. It is coming from respiratory alkalosis, maybe because this gentleman has pneumonia, he's breathing out a lot more CO2. Then people tend to say, okay, we'll stop here. Now the problem with I'll show you what the problem with stopping here is. So you identified the primary respiratory alkalosis. The next step would be, let's say this is acute respiratory alkalosis. Carbon dioxide has gone down by 1 lot of 10 from 40 to 30, which means your bicarb should go down by 1 lot of 2 from 24 to 22, but it's gone down to 21. That should give you a clue. Bicarb has gone, it never overcompensates. It looks like the bicarb has gone down a bit more. The next step always should be to measure the anion gap in any gas. So let's check the anion. So you identified a primary respiratory disorder, but you also check the anion gap. So let's say the anion gap here is 98 plus 21, 9 there, 11. So 119, 145 is the sodium minus 119. So let's say 120 instead, 5, 2, about 26. So there is a high anion gap metabolic acidosis present. Now, when I say that, the next step, so there is high anion gap metabolic acidosis, probably because this gentleman is septic, critically ill, underperfused from the pneumonia, hypoxemic, lactic acidosis, but the anion gap is 26. 26 minus 12, which is normal, is 14. You add the 14 to the 21, which makes it corrected bicarb. Corrected bicarb is 35. So this guy has a primary respiratory alkalosis, a high anion gap metabolic acidosis, and also a metabolic alkalosis from the diuretic therapy, from the Lasix that he's been given. And this is a classic example of a triple disorder. If we haven't done the anion gap, if we looked at the pH, explained the pH change with carbon dioxide change, and walked away, we would have missed 2 other disorders in this gentleman, which also tells us how sick he is. Right, so 27-year-old lady presents to ED with acute renal failure. Her initial blood gases show, so pH is 7.12, acidemic. Carbon dioxide is alkalemic. So carbon dioxide change is not explaining the pH change, which means she's got metabolic acidosis. Simple. So the next step would be expected CO2. So last 2 digits of the pH, 12 plus 4 is 16, minus 4 is 8. PCO2 is 13, it's within that range. Great. So compensated metabolic acidosis. What is causing the metabolic acidosis? Let's see. So let's see, next step is to calculate the anion gap. 140 minus 115 plus 4 is 119. So anion gap is 21. So there is a high anion gap metabolic acidosis from the renal failure. Now we won't stop there. We look at 21 being the anion gap, subtract 12 from it because that's the normal, you get 9. You add 9 to the bicarb of 4, you still get 13. You're not normalizing bicarb. Bicarb is still way under 18, which means along with a high anion gap metabolic acidosis, she's got a normal anion gap metabolic acidosis, maybe from the saline therapy that she's received in the emergency department when she came in with renal failure. She's got dual acidosis present. Next one. So a 45-year-old man presents to emergency department unconscious with seizures. He's hypotensive and febrile. So these are the initial investigations. So I'll give you all, this probably is the last example. I'll give you about half a minute or a minute to go through. Okay, so the primary change in pH is alkalemic. Does the CO2 explain the primary change in pH? Yes, it does. There is a respiratory alkalosis. Okay, can we all go home now? No, we can't. So what we need to look at is, let's say this is an acute respiratory alkalosis, patient is having seizures. So you need to look at, so how many lots of 10 has the carbon dioxide gone down by? About 1.5 lots of 10, which means you expect the bicarb to go down by about 3. It hasn't gone down by 3. You're like, it hasn't. It's not compensated respiratory change. So the next step is anion gap. If you look at this guy's anion gap, his anion gap is 52. About 40 more than normal. Massive anion gap. So this gentleman has a high anion gap metabolic acidosis as well, along with the primary respiratory alkalosis. So we need to now look at 52 minus 12 is 40. Add that to the bicarb, 40 plus 23. Again, 63. Bicarb is way high. So this gentleman has a primary respiratory alkalosis, high anion gap metabolic acidosis, and also a metabolic alkalosis. So that's again another example of a triple disorder. Okay, hope it all makes sense. That's it. Open for questions.
Excellent presentation, Dr. Veeru. It was actually ABG made easy by you. So any questions are invited. Bashir, you can unmute everybody. Any questions? So there is one.
It looks like night time for you too.
Are you able to see the chat box, Dr. Veeru?
Yeah, I'll have a look. Maybe if I stop sharing, that might help. I'll pause share more. Yeah, I can.
There's one question there.
Okay, yeah.
Why potassium is not useful in calculation when it is readily available?
Yeah, so potassium is useful. The thing is, if you look at sodium, chloride, and bicarbonate, the normal amounts are quite high. So bicarbonate is 24, chloride is anywhere between 100 to 110, sodium is about 135 to 145. But if you look at potassium, you have a very tight normal range, anywhere between 3.5 to 4.5 or 5. So you might, by using potassium, you're actually causing a change of 1 or 2 millimoles. So if you want to use potassium, you just have to make the normal anion gap 16 instead of 12, because usual potassium is 4. So it's not about why potassium is not used. My argument is potassium is not necessary to be used, because by the time potassium there is a big change in potassium. For example, potassium is 8, patient is dead. You're dealing with some other problem than acid base. Does it make sense? So, or potassium is 2, you'll have a severe arrhythmia. So potassium is maintained within a very tight range. The change in potassium is not big for us to worry about, right? That's why potassium is not necessary to be used. But if you think the patient's potassium is in the 6s and 7s, you can use potassium. It's fine.
Any other questions? I think they've understood ABG very well. So no further questions, Dr. Veerendra.
Hello.
Thank you.
Hello.
Hello, yes.
Yeah, I
Good evening,
think
sir. Dr. Veerendra.
yes, I am Dr. Ravinder Beti,
Hi.
Hyderabad. Your lecture is excellent, but I think the respiratory compensation is possible only from spontaneously breathing patient. In mechanically ventilated patient, we can't use these calculations in my.
Yeah, that's absolutely. So when what I was trying to say about respiratory compensation is you are looking for whether respiratory compensation exists or not. So yes, you're absolutely right. In a mechanically ventilated, controlled mechanical ventilation, where you control the patient's ventilation, yes, you're correct that respiratory compensation is not possible because you have taken over. But if you do allow the patient to breathe, even mechanically ventilated, maybe then there is some amount of compensation possible depending on how much sedated they are. So that's actually a very good point. In patients who are very, very acidemic, we tend to wait and hold on before we intubate them, because once we intubate them, most of their compensation is gone and you end up with a much worse pH. So sometimes it's not unusual in our ICU to actually wait for them to correct their primary problem and improve in terms of metabolic acidosis before we intubate, if it makes sense.
And please see my other entries into this chart box.
Yes, I am. Better this is presented in double slides to old show for calculations. Yeah, point noted. Thank you.
Yes. And also we are generally seeing the carbon dioxide as 40 instead of showing the range as 35 and 30, between 35 and 45. Suppose this patient's normal is 35 and we expect a increase in carbon dioxide, and the calculation from 40 onwards will give a false value, I think.
That is correct. So because if you know the patient's usual carbon dioxide, and that is documented not on one admission, but for multiple admissions, that this patient's carbon dioxide is 38, for example, you can use that particular value for that patient. If you know the patient well, there's nothing wrong with that. What I mentioned was for the purposes of this talk, using 40, because with none of these examples, we don't know their normal values. So that's if you clearly know the patient well, and that's more than one admission that they had, or more than one occasion they had a particular carbon dioxide value, then it's entirely appropriate to take that value as their normal. What I was trying to say is, you can't do these calculations by saying, okay, I'll take a range. You have to pick a number and then do these calculations. And that is understood that there is a certain amount of error expected, but not a massive error. Within 2 or 3 points, the error is expected and has to be accounted for.
But I think in the clinical scenario is very acute, and you can't have the older normal value of the patient. And
correct.
Okay, it is only a guideline. It is not.
Correct. In the clinical scenario, when it is acute, my recommendation and what I do in my practice is to use set values of 7.4, carbon dioxide of 40, bicarb of 24, anion gap of 12. Use that, and most of the time you shouldn't go wrong by using those values.
So what I mean is, in the ICU we have less time and most of the residents are juniors, and meanwhile while they are learning, is there any available app that will give a ready measurement of the status of the patient in view of ABG?
I am so sorry to tell you, I don't know about any app. If you want to do intensive care, if any junior wants to do intensive care,
Yes.
My humble suggestion is for them to learn blood gases proper. There are some basics. So, for example, we are anesthetists, right?
Yes.
You don't want them to say, okay, there is a robot for intubation. You want to learn intubation. What if the robot fails? What if the app fails? So
Yes.
my suggestion is ABGs are not difficult to learn. And if they spend a year or two learning them, they should be able to learn them. So for anyone who wants a career in intensive care, they should be able to know how to interpret a blood gas.
Can you please tell what is the role of sampling error? Because sometimes the people will take VBG thinking that it is ABG.
Yeah, look, for the purposes of blood gas analysis, venous blood gases, I have to say that I'll use the term, they are not bad. Look, they are not the be all and end all, considering you will have, we all know that there is a higher carbon dioxide content in the venous blood, and there is also higher lactate content in the venous blood. So when you say lactate of 2 is normal, up to 4 is normal in the venous blood. So, and that's because it's before it's being processed by the lung, lactate is also processed by the lung very well. You can see a higher lactate content and a higher carbon dioxide content. So people can overdiagnose respiratory acidosis. Then people can also overdiagnose metabolic high anion gap lactic acidosis. So, but not by much. So if you understand that there is that, you might be overdiagnosing it. If you assess that in correlation with clinical correlation of the patient, venous gas in certain circumstances is not unreasonable.
Thank you.
Thank you very much.
Anything else, sir? Okay, I think that's it, and there are no more questions. Thank you, Dr. Veerendra, for this excellent presentation. We'd like
you,
you to give us some more lectures in future. So
thank you, ma'am.
Thank you very much. Thank you all for attending this
Thank you very
webinar.
much. Thank you.
Thank you, sir.
Thank you.
Any other suggestions from you, Dr. Pawan?
There's one more question.
Any other suggestions?